Welcome to this video on pulmonary embolism, or PE. We will explore clinical excellence and nursing management related to PE, with a focus on being exam ready. Let's start with a question. Which component of Virchow's triad refers to stagnation of blood flow, a major risk factor for PE? Is it hypercoagulability, vessel wall injury, venous stasis, or fibrinolysis? The correct answer is C, venous stasis. Virchow's triad includes venous stasis, which is flow stagnation, vessel wall injury, and hypercoagulability. Stasis is key for clot formation. Next question, what is the most definitive diagnostic test to confirm a pulmonary embolism? Is it chest X-ray, CT pulmonary angiography, arterial blood gas, or D-dimer test? The most definitive diagnostic test is B, CT pulmonary angiography, or CTPA. CTPA is the gold standard for visualizing a clot in the pulmonary artery. Remember, D-dimer is a screening tool, not a diagnostic test. Which classic ECG finding is occasionally seen in patients with significant pulmonary embolism? Is it the S1Q3T3 pattern, street elevation, prolonged PR interval, or wide QRS? The correct finding is A, the S1Q3T3 pattern. This refers to an S wave in lead I, a Q wave in lead 3, and an inverted T wave in lead 3, suggesting acute right heart strain from PE. If a patient with a suspected PE becomes hemodynamically unstable, what is the priority nursing action? Administer warfarin, position in Trendelenburg, oxygen therapy and hemodynamic support, or send for CTPA? The priority action is C, oxygen therapy and hemodynamic support. Remember to prioritize ABCs. Hypoxemia must be corrected immediately. ACTPA cannot be performed if the patient is unstable for transport. Heparin is administered for PE. What is the reversal agent for heparin overdose? Vitamin K, protamine sulfate, flumazenil, or calcium gluconate? The reversal agent is B, protamine sulfate, which is the specific antagonist for heparin toxicity. Vitamin K reverses warfarin. What type of shock is most commonly associated with a massive pulmonary embolism? Hypovolemic shock, cardiogenic obstructive shock, anaphylactic shock, or neurogenic shock? The answer is B, cardiogenic obstructive shock. PE causes obstructive shock by physically blocking blood flow to the lungs, which prevents right ventricular output. When a patient is on heparin infusion, which lab value must be monitored? INR, PT, APTT, or serum creatinine? The correct lab value to monitor is C, APTT, or activated partial thromboplastin time. Heparin therapy is monitored via APTT, while warfarin therapy is monitored via INR/PT. Let's review another classic symptom of PE. Which of the following is a classic symptom of PE? Is it productive cough, sudden onset dyspnea, bradycardia, or unilateral peripheral edema? The correct answer is B, sudden onset dyspnea. Sudden, unexplained dyspnea is the hallmark symptom of PE. Tachycardia, not bradycardia, is common. What structure is visualized here in a CTPA, confirming an embolism? Is it a pleural effusion, a thrombus in the pulmonary artery, an aortic dissection, or a pneumonia infiltrate? The correct answer is B, thrombus in the pulmonary artery. A filling defect in the pulmonary artery on a CTPA image is the diagnostic evidence of PE. Which risk factor fits the hypercoagulability aspect of Virchow's triad? Is it a long-haul flight, stasis, oral contraceptive use, a central venous catheter, injury, or bed rest? The answer is B, oral contraceptive use. Oral contraceptives elevate estrogen levels, which increases the risk of clot formation, classifying it under hypercoagulability. What is the therapeutic goal for INR in a patient on warfarin for PE? Is it 1.0, 2.0 to 3.0, 4.0 to 5.0, or 0.5? The therapeutic goal for INR in PE patients on warfarin is B, 2.0 to 3.0. This range is necessary to prevent recurrent thrombosis while minimizing bleeding risk. Which sign indicates DVT, the precursor to most PEs? Is it Hohmann's sign, Cullen's sign, Murphy's sign, or Koenig's sign? The correct answer is A, Hohmann's sign. This sign, though unreliable, is classically associated with deep vein thrombosis, which precedes most PEs. What is the immediate priority intervention for a PE patient complaining of severe chest pain? Is IT administering IV fluids, performing an ECG, administering oxygen and analgesia, or preparing for mechanical ventilation? The immediate priority intervention is C, administering oxygen and analgesia. Addressing oxygenation and pain relief is crucial for stabilizing the patient's condition. Which of these is part of Virchow's triad? Is it tachycardia, venous stasis, hypotension, or hemoptysis? The correct element is B, venous stasis. Virchow's triad includes venous stasis, vessel wall injury, and hypercoagulability, which predispose patients to thromboembolism. Which drug is a thrombolytic used for massive PE? Is it warfarin, alteplase, heparin, or enoxaparin? The correct thrombolytic agent for massive PE is B, alteplase. Thrombolytics like alteplase are potent clot busters reserved for life-threatening PEs due to high bleeding risk. Let's consider the lab results. What lab result usually prompts further investigation for PE? Is it low hemoglobin, high D-dimer, high troponin, or low platelets? The correct answer is B, high D-dimer. An elevated D-dimer suggests the presence of fibrin degradation products, indicating clot formation and breakdown, which warrants further PE investigation. Which patient position helps improve respiratory status in PE? Is it Trendelenburg, supine, high Fowler's, or left lateral position? The best position is C, high Fowler's. This position maximizes chest expansion, improves ventilation perfusion matching, and reduces venous return to the right heart easing strain. Which assessment finding is a sign of right heart strain? Is it jugular venous distension, peripheral pallor, bounding pulses, or crackles in the lungs? The correct answer is A, jugular venous distension, or JVD. JVD is a key sign of increased pressure and strain on the right ventricle, often seen in significant PE. What is the best way to prevent PE in post-op patients? Is it aggressive fluid restriction, early ambulation, high-dose anticoagulation, or strict bed rest? The best preventative measure is B, early ambulation. Mobility prevents venous stasis, addressing the core mechanism of DVT-PE formation. If a patient on warfarin has an INR of 7.0, what should the nurse anticipate? Anticipate increased warfarin dosage, administration of vitamin K, initiating heparin infusion, or discharge planning. The nurse should anticipate B, administration of vitamin K. An INR of 7.0 is highly supertherapeutic, indicating a high bleeding risk that requires reversal with vitamin K. Which medication is a LMWH, low molecular weight heparin? Is it warfarin, enoxaparin, heparin, or rivaroxaban? The correct LMWH is B, enoxaparin. Enoxaparin is frequently used for DVT-PE prevention and treatment due to its predictable dosing and subcutaneous administration. Finally, what is cor pulmonale? Is it left-sided heart failure, right-sided heart failure due to pulmonary hypertension, a type of shock, or an abnormal heart rhythm? Cor pulmonale is B, right-sided heart failure due to pulmonary hypertension. It is a potential long-term complication of recurrent or chronic PE.